You mentioned something earlier about dentures and vertical dimension. Ironically, I'm probably a little bit more concerned about opening the vertical in an edentulous patient than I am in a dentate patient, because it's much more harder for them to adapt because they don't have the proprioception. So composite will obviously be non-invasive. We're probably not going to be prepping the teeth at all, but patients need to be aware that whilst there's going to be less cost, I'd consider it as a long-term provisional, because
transitional almost.
Transitional, yeah, absolutely. I mean, ideally, if I am doing restorative, I'd rather not whiten first, because if we have our super thin restorations and our whitening result over time will fade, it's much harder to top that up if you have a restoration. The first step in equilibration is to be able to manipulate someone into centric relation, and 90% of the population have a slide from CR, centric relation, to CO, centric occlusion, habit bite, whatever your terminology. And the first step in equilibration is...
So we've talked about this big topic before, vertical dimension in restorative dentistry. Me and Mahmood did an episode basically reassuring you that you can safely raise the vertical dimension and that we shouldn't be so scared of it. What I do in this episode with Dr. David Bloom is really lean on his decades of experience in comprehensive dentistry to delve deeper into the intricacies of opening the vertical dimension, the staging, the phasing, the planning, and a full walkthrough of how Dr. David Bloom does it. And you know what? There's many different ways to go about it. In fact, for those of you who can see me who are watching this, I'm a bit more formally dressed. I'm not wearing my hoodie. I was actually at an occlusion symposium today. And you had these great speakers in occlusion like Paul Tipton and Corey Farran, Tiff Qureshi, and these guys were talking about the importance of canine guidance. And then you had Ken Harris, also a legend in occlusion and one of the mentors on COIS. He did not care for canine guidance. It was irrelevant, it was not important. And if you go back into the archives of Protrusive podcasts, you remember 2 episodes we did with Dr. Andy Toy about the posterior guided occlusion, where actually we don't want canine guidance. So it goes to show, my friends, that in the world of occlusion, there's many ways to do it. Learn one way, learn it well, it will serve you well. And then the benefit of learning the other ways is that sometimes you'll find a patient that really fits into that box a little bit better. For example, for many years, I didn't use a COIS appliance. I had my ways of deprogramming that I was very happy with. And just a couple of years ago, I did my first COIS, and I've done a few more since then. And there are certain patients and characteristics that just are very amenable to that way of doing it. But then for most of my patients, I use a leaf gauge. There's 2 types of patients. There's loosey-goosey and tighty-whitey. The tighty-whitey patient, we all know this patient, right? It's the one where you're trying to do some manipulation, you're trying to seat the joints, and their mandible is just so stiff. Whereas you have the much nicer loosey-goosey patients where you don't have to work very hard to deprogram them or get everything nice and relaxed and hinging. And these 2 patients will need a different type of deprogramming. So I say learn one school, one occlusal religion well, and then start looking at the others. And I think there's so much to learn from all the occlusion camps. Just like I said, 2 polarizing views I was listening to today on canine risers and whether canine guidance is even important at all. And you know what? I subscribe to them both. And you're thinking, Jazz, that's not possible. How can you serve 2 masters? Well, you can, because our patients are so variable. They're so unique. That's what actually makes our dentistry fun. If every patient was the same, it would be boring. But our patients come with these unique challenges, these unique presentations. And we have to sometimes be very creative in how we treat someone, how we arrive at treatment decisions. And let me tell you, learning about the different occlusal religions has made me a better, more rounded clinician. But for many of you listening early in your career, honestly, just pick one religion. Whether that's the COIS religion who don't believe in canine guidance and certainly don't believe in anterior guidance. In fact, the anterior teeth should hardly touch. Or you might go more Dawson, whereby anterior guidance is very important. And you know what? The secret is that both these camps work. So pick one, lean in, learn it well, and eventually critique the others, learn about everything. And that, my friends, is the Protrusive Dental Pearl for today. If you don't really have an occlusal philosophy, learn one. If it's from me and Mahmood and the OBAB philosophy as a foundation of occlusion, great. If it's from COIS, amazing. If it's from Dawson, super, Pankey, whoever, learn a school of thought. But then the second degree of this pearl is that once you've learned a school of thought and you've got some cases under your belt, then be willing and respectful for the other sides. Listen and appreciate other views. They will make you a better clinician. Hello, Protrusive, I'm Jazz Galati, and welcome back to your favorite dental podcast. Once again, David Bloom is back on the podcast today. We covered minimal preparation of veneers last time, and today we talk all things vertical dimension. I hope you enjoyed this deep dive, and I'll catch you again again in the outro. Dr. David Bloom, welcome back again to the Protrusive Dental podcast. Last time we spoke about veneers, something that you're so experienced in. This time we're talking about something similar, because quite often you're doing veneers, but you're also doing, as part of a full mouth rehab, you're opening the vertical dimension. And there's so much we can talk about. But in this taster today, we're going to ask some really key restorative questions from someone who's got so much experience in yourself. For those people who didn't listen to that episode, can you just tell us about yourself, your passions, David?
Yeah, well, I've been qualified 36 years now. I'm a GDP. I was in the same practice for 24 years, which teaches you about failure, what works long term, what doesn't work long term. And having done that, passionate about cosmetic dentistry, but also about doing it as responsibly as possible, which means as minimally as possible. And so we talked about an additive wax up and how that can allow a visual try-in to confirm the aesthetics and then allow us to prep only where we need to.
So guys, if you haven't checked out the episode we did on minimal preparation of veneers, David, as I joked on the Protrusive Guidance app, David has gram for gram done more veneers than I have consumed peanut butter, and I've consumed a lot of peanut butter. That was my silly joke at the time. But you're very humble. David's also ex-BACD president and big time educator as well. So I want to, at the end, do encourage you guys to do check out his stuff, which is amazing. Let's get the little details of restorative, right? It's such a big topic in a way, David. It's actually quite a challenging one to record, but I'm just looking forward to just geeking out with you on such a awesome topic when it comes to restorative. Of my own personal journey, David, and you may remember this as well, when you're starting out, the level of training that you accumulate from dental school and stuff, like everything is conformative, and then when you have an opportunity to open the vertical dimension, like you're learning just to deal with caries, then you're learning to deal with, the very foundations. It seems like a big step at the time to open the vertical dimension. And I remember the first few times I did it, is the patient going to survive? Is their head going to pop off? Are they going to be able to chew? And that kind of stuff. And once you do it a few times, you almost become a little bit blasé about it. But you kind of need to do it a few times to realize that actually the human body is amazing at adapting, providing we conform to a few rules. So we were going to come on to that. But just at the macro level, David, how do you explain to young dentists, okay, how do you arrive to the decision to open the vertical dimension?
Well, I think first of all, you have to have a thorough understanding of occlusion, as I'm sure you would agree. And if you think about it, when we do occlusal appliances, flat plane appliances, we are opening their vertical. And as you say, the body is remarkably good at adapting as long as we stick to our occlusal principles. And I think once you also know how to do an equilibration, which I think is essential, it gives you the confidence to be able to move on. And it's a reorganized approach as opposed to a conformative approach, as you say. But once you have the confidence in occlusion and you can open verticals, it becomes less of a step. And what it does allow is us to be a lot more conservative because we're giving ourselves space. So when do we do it? Well, it's always an option when we're treating the lower arch to consider. And one of the classic times to do it is if we have a deep bite. And a deep bite, and I think we alluded to this in the last episode, especially what I see as I practice more and more class 2 div 2s, we see a lot of wear going on because they have effectively a restricted envelope of function, an increased overbite, maybe a restricted overjet. And opening the vertical simply gives us space to add here and to add occlusally. So certainly a deep bite. I think wear cases, historically, we'd have done a lot of maybe crown lengthening, conventional classic crown lengthening, but that's obviously quite invasive. And with wear cases, obviously crown lengthening is still an our armamentarium, and with additive composites, we may be looking at dial, which is maybe an interim, it's maybe a different conversation again, but we can be additive and again open the vertical. But with dial, I wouldn't want to go straight to porcelain. I think it's probably too abrasive in that situation. So I'd be looking at composite, and composite is going to have less longevity. So composite will obviously be non-invasive. We're probably not going to be prepping the teeth at all, but patients need to be aware that whilst there's going to be less cost, I'd consider it as a long-term provisional because
transitional almost.
Transitional, yeah, absolutely. Because longevity may be 5 years, maybe longer, but it's not going to have the same longevity of porcelain where we're talking maybe 10 to 15 years. So again, first few times I was doing it, I might have been happier to do it in composite and stage, but if we know we're going straight ahead, a wear case is often a case where you may open a vertical as well. And then obviously small teeth is a time we may do it out. And I'm not concerned too much about the size of the teeth in that sense, but it gives us the possibility. But even a classic class 1 case, it's always something we have in our armamentarium. And I suppose it's considerate, but I'm not advocating it for every case, but it can be very useful to have in our toolbox.
I think if it was just, so many different things that we could talk about in terms of arriving at that decision and a flowchart and stuff, but I guess if there was one overarching theme or one word to use, I would say it's space as the primary thing, right? You need space to solve a problem. You need space because when the patient bites together, there's no space to restore their missing lateral. You need to open them up to give them that tooth. You have completely worn teeth. You need to open it up to actually get aesthetically looking teeth, as well as potentially looking at the gingival stuff. But I think that is a primary driver, and a lot of the principles we can learn, like with aesthetics, as you know, David, complete dentures, we learn so much about that, and we actually forget that actually we're moving very fluidly, dynamically, the vertical dimension in complete dentures, and sometimes we forget that. Now, you mentioned a few really interesting things. I just want to just talk about this because I think it's really important. Like you mentioned the word equilibration, and I'll tell you something, David. You mentioned the word equilibration to anyone who's maybe less than 10 years qualified, and like they are trained in an era where that's a dirty word, right? So can you just clarify what you mean when you say, as part of opening vertical dimension, you should have a skill set of equilibration? Just because I think it is a lot more simpler than what can be interpreted. Just explain that part.
Sure. First of all, if the dentist can't say equilibration, they probably can't do it. That's something I've learned over the years. But an equilibration is a way of idealizing someone's occlusion to eliminate the interferences. And the first step in equilibration is to be able to manipulate someone into centric relation. And 90% of the population have a slide from CR, centric relation, to CO, centric occlusion, habit bite, whatever your terminology. And the first step in an equilibration is removing that CR-CO slide.
Okay, guys, interjection number 1. What is deprogramming, and how do you manipulate their jaw into this centric relation? What is centric relation, right? Let me just break it down. Centric relation is essentially a stable position of your condyles, nothing to do with your teeth. If we imagine very crudely that your condyles are like balls, right? You got the left condylar bone and you got the right condylar bone that roughly look like two potatoes, right? And we're essentially seating them into the cups, which the cups are the fossae. So balls into the cups. It's like your shoulder being seated into the shoulder socket. I say that because I've got a history of shoulder dislocations, but I remember one time they were relocating my shoulder and whoop, it just slipped right in. The ball of the joint just goes right into the fossa. So crudely speaking, we want to get that into position because it's a repeatable position, it's a comfortable position, and it's somewhere we can keep going back to if we lose our way, if we're confused, where are the teeth supposed to be? Then if you keep taking the balls back in the cups, then you have a point of reference. But to be able to do that, the muscles are always fighting you because the muscles have learned this existing bite, which is not in centric relation. Your condyles the balls are not in the cup. So to manipulate someone, you first need to release their muscles. You need to relax their muscles to allow the condyle to seat, to allow the ball to go into cup. And that's all to do with the joints, not the teeth. But then certain teeth will hit when you go into centric relation. So there's lots of different ways. And what we teach in our occlusion course is there's hands-off approaches and there's hands-on approaches. Like hands-on is imagine bimanual manipulation, right? So you get your hands in this awkward way around the mandible and you try and manipulate the condyles into the fossae. That can be quite tough, especially for a beginner. That's not an easy thing to learn. And also when you get the patient to curl their tongue all the way to the back, that's kind of like a forced position. Whereas I like hands-off approaches. This is using things like a leaf gauge, something called a Lucia jig, which we'll have another interjection for coming up, or an occlusal appliance. Essentially, it's allowing the back teeth to separate and allowing the muscles to guide the jaw into this repeatable position, centric relation. So hands-off approaches and hands-on approaches. Let's listen to the episode and let's build from there in the other interjections.
Once someone's in CR, they're obviously much easier to manipulate. They tend to have relaxation, neuromuscular release of their muscles. And then we're looking at eliminating any interferences in our lateral movements. And so it's a process of learning how to do that. And I know I shouldn't use my hands because those people who are listening...
Just describe what you're doing.
But when you're going back, you tend to find the contacts are on the mesial slopes of the uppers, the distal slopes of the lowers. And by adjusting those contacts, you'll get to a point where CR and CO are coincident. Then the next stage is to ensure we have anterior guidance, so anterior disclusion in lateral excursions. So we're then removing our...
Do you mean posterior disclusion in lateral excursions?
Sorry, yes, I mean exactly that. Posterior disclusion in lateral excursions and removing those interferences. And if we're going laterally, if we're going to the right, that's then going to be on the palatal facing slopes of the uppers and the buccal facing slopes of the lowers. And I use this terminology to help patients understand as well. And so we're getting to a point where CO and CR are coincident and we have immediate anterior disclusion in excursions.
Excellent. And I just want to add to that as well in terms of equilibration. Like sometimes to young dentists, like what you described is the classic approach to equilibration, but much more fundamentally on a day-to-day basis. How can we make it more relatable day-to-day? Imagine that class 2 Div 2 patient that you described, and you are going to do all the steps to open the bite a bit, to fill in the space posteriorly. When you fit the restorations, there will be some adjustment to do, right? The left side might be heavier than the right side. Even just to get that degree of balance between the left and the right, something just so foundational, we just do it. We do, you do your composite and the composite's proud. When you are adjusting that composite, you are in a way equilibrating, if you like. You're trying to achieve harmony and balance, and so it blends in with the rest of the dentition. And when you think of it like that, and then you think, okay, what are my objectives and goals I'm trying to reach? So when we're doing a class 1 composite, if that composite that you just placed, take the rubber dam off, bite together, that's the only tooth in the bite. Well, your goal is to go back to how you were at the beginning and have every tooth biting, if that was the case of your patient. And you know your goal, and equilibration is the means to get there. And it's important to remember that, that is it. And then when you're doing these bigger cases, then we have our goals that we want to be in centric relation in many schools of thought. It's a utility position. It's a repeatable position, as you said. And so equilibration allows us to get there. And on that topic again of the class 2 Div 2 patient, David, when you have that deep bite, right? When you have the wear on the incisors. Here's a good question, right? Opening the vertical dimension versus orthodontics. How do you arrive at the decision that, okay, I'm going to open the vertical dimension versus actually, let's just intrude those incisors, level out the curve of spay orthodontically, and give this patient a result by ortho?
Well, you bang on, and I've made just a couple of notes, and I will answer that. But going back to equilibration, what you were describing is an occlusal adjustment when we fit a restoration. Absolutely. We are adjusting the occlusion, but in a conformative approach. So we're working in centric occlusion. I suppose the biggest difference for an equilibration is that we're going to a repeatable position, CR, because that's our go-to point, but we're working it as a reorganized approach rather than a conformative approach. And you mentioned something earlier about dentures and vertical dimension. Ironically, I'm probably a little bit more concerned about opening the vertical in an edentulous patient than I am in a dentate patient, because it's much more harder for them to adapt because they don't have the proprioception. So just a couple of points to cover there. Going back to the class 2 Div 2, I think we do have to be very aware that whilst we may be giving ourselves space in a situation like that, we're not actually addressing maybe the fundamental issue, which is the restricted envelope of function. And if we don't correct the reduced overjet, because we can correct the increased overbite by opening our vertical, if we're not correcting the retroclined nature of the upper anteriors, we are potentially inviting more wear, especially if we're treating the lowers in porcelain, because porcelain can be more abrasive. So absolutely there is a case to be made for pre-aligning patients, especially with a class 2 Div 2, because we may be solving one problem but swapping it for another. When it comes to the leveling the curve of spay, that's less of an issue for me restoratively, because actually we can add to the occlusals of the lowers without doing any preparation. And so that's when I wouldn't be so concerned about not doing pre-restorative orthodontics. But for the restricted envelope of function, I think it is important. You may be choosing to go full coverage on the uppers, in which case that wear is potentially going to be less of an issue. But if you're leaving the palatal of the uppers, then we may be not causing wear on the lowers, which is what we tend to see in an aged patient in a class 2 Div 2, but we're going to then have palatal wear on the uppers, potentially moving down the line. And again, I think in any of this...
Okay, interjection number 2, restricted or restricted envelope of function. To put it simply, it's like there's a lack of chewing space. Like if you go back to basics, there's a certain movements that the jaw can make. That's the envelope of motion, i.e. your lower incisors can go all the way forward, protrusion, all the way back, retrusion, all the way left, right, opening. So there's only so many different places your jaw can go. But chewing only happens in like a small, classically teardrop shape, right? It's a teardrop shape, and that's where the magic happens. That's where chewing happens. That's where speech happens. But if this envelope is constricted or restricted, it's like you don't have any space at all. So like there's a lack of overjet, and your lower teeth are like right behind your upper teeth. There's a real lack of overjet. And as you're chewing, these teeth are like rubbing together. So it's high frequency and low intensity. So it's not very forceful, but it's happening several times a day. Every time you close your teeth together, your teeth are potentially rubbing. So classically, you get wear of the palatal of the upper surfaces and the incisorofacial of the lower surfaces. And you see patients all the time like this, where they just don't have any chewing space. And so that's the consequence of trying to work with a restricted or a constricted envelope of function. And these cases often need orthodontics primarily, or at least raising the vertical dimension, but primarily orthodontics because it is a tooth position problem, a jaw position problem. And it's a really important aspect to grasp. A night guard is not going to fix this. It needs space. So there we are. That's that interjection done. Thank you.
When we're opening the vertical, what we've got to be aware of is the length of the lower incisors, because that is going to dictate whether the uppers can just be facial, as in veneers, or if they then have to be full coverage. And then when they're full coverage, we can't call them veneers because they're not veneers, they're crowns. And therefore not going to be maybe as conservative, ironically, if we're going full coverage. But all of this is worked out pre-preparation with, again, our visual try-in. So we've got an additive wax up. One has to think three-dimensionally. Are we going to have to cover the palatal of the uppers? That depends on the length of the lower incisors. And we spoke last time about our smiling teeth on the uppers and our talking teeth on the lowers. We don't want to have especially long or extra long lower incisors because that's going to be too visible. But with our visual try-in, we're working this all out pre-operatively. And we shouldn't be afraid to be equilibrating our visual try-in, making adjustments. You should be able to contour because it all needs to be worked out. But when we're adjusting our visual try-in, I may even equilibrate that. And at that point, I'll take new putties because I don't want to have to go through that process again. But we know that we're one step closer. We've checked the aesthetics. We've checked the occlusion. And so again, it's not a quick fix, but it's in a logical pathway, a very useful item to have in our toolbox, but done in the same predictable diagnostic manner. So working out the length of lower incisors, that's going to determine what we have to do with the palatal of the upper incisors. And going back to your question, we need to be aware that we may get space, but we don't want to be causing a separate problem, which would be wear. So absolutely a class 2 div 2, I would think of some pre-restorative orthodontics to correct the retroclination.
I think sometimes, in those cases, it's a bit like if orthodontics would completely solve their aesthetic and functional demands, then that probably might be the best way to go. However, if they have crowding, that's going to mean that you're going to have to be more invasive, all right? Or I sometimes find it helpful to tally up which teeth actually genuinely need restorations. And if that number is getting higher and higher and higher, I'm thinking, well, if I have to do orthodontics and then restore all these teeth anyway, can I bypass the orthodontics and just restore these teeth and achieve the shapes and aesthetics that I want? You made a great point about the retroclination of the upper incisors. Sometimes, that is going to be the main killer of your case. Sometimes it can be good because it gives you so much space to come labally and be minimally invasive. But if that torque is wrong, that loading after your restorative is going to be problematic. And so sometimes that's the reason. And then even things like if they've had ortho before and now they've got root resorption, then you want to try and they've relapsed and you want to maybe avoid ortho and therefore restorative is more favorable. So you got to really look at it globally. But I'm glad you mentioned those points. Have you got something to add there? Sorry.
Yes, I have. I think we have short-term orthodontics. It doesn't necessarily have to be comprehensive ortho to give an ideal class 1 result. And we spoke before about anterior tooth alignment. I think the days of instant orthodontics with veneers is gone. It's something we maybe did because we thought everything took 18 months or more of comprehensive ortho. But to correct those retroclined upper incisors really doesn't have to take a long time. I said a lot of the times class 2 div 2, leveling the curve of spare, as we said, is also not an issue. And ortho is a great option, but ortho is not going to correct size and shape, and also isn't going to deal with heavily restored teeth. And so, as you say, it's planning it. And if we've got virgin teeth, then we're probably going to look at more orthodontics than if we've got heavily restored teeth. But orthodontics can't correct size and shape. And whitening is a great tool. But if patients, as we touched on before, live in Essex or Liverpool, they may want to be going significantly lighter than B1. And again, that's a time where a restorative solution may be necessary because B1 is quite a bright shade, but not for everyone. And sometimes we can whiten beyond B1, but I'm not going to guarantee it. I'm fairly confident most of the time to get to B1, but not beyond. So there are times where orthodontics alone is not enough for very many reasons.
Great point. And just on that whitening, I've noticed over the years that patients, despite me trying to manage their expectations and stuff, patients are less and less made up and overjoyed from the results of just whitening. I think the more I'm realizing is that actually if I listen carefully, then perhaps I should have said that whitening is a stepping stone to the shade that you want, or perhaps we should go for the restorative. And then when they have the veneers done, they're like, yes, this is what I wanted kind of thing. And so I've noticed that the expectations and trends and desires are definitely increased for patients.
Yeah, absolutely. Whitening is predictable, but we're going to have darker cervicals, however we look at it, because that's what natural teeth have. And if people want a different look from that, but I think we should also Whitening is very safe, it's non-invasive, as you say, potentially an entry level, but from a cost perspective is much lower ticket item. I mean, ideally, if I am doing restorative, I'd rather not whiten first, because if we have our super thin restorations and our whitening result over time will fade, it's much harder to top that up if you have a restoration. So if I'm doing, and if I think it's important we know if the patients have whitened, so the lab can maybe factor that in and using maybe a more opaque ingot if we're using Emax, for example, because as the result fades, it's harder to top it up. Whereas I'd rather get the color shift knowing that the foundation shade was darker. We're going to get that color change in the porcelain rather than have whitened first. But as you say, whitening isn't enough of a change for some patients, and we can't always whiten the cervical as much as they want to, whereas porcelain gives us a few other options.
I think nowadays I'm a little bit wiser from my experiences, and I will show patients realistic photos like, look, this is what to expect. You know, my patients who are, you know, I treat a very aging population in a village type practice, and so I'll show them photos of cases where, you know, there's been a moderate improvement. That, you know, this is what I can get you, but if you want to go for this, then maybe it's you know, looking at a different approach. And then, just like you said, the cervical is not the same as the enamel that's more in the body, and they're not going to whiten in the same way. Going back to vertical dimension, when I was starting, and you know, DAL is like a gateway drug into occlusion. DAL is like a gateway drug into opening the vertical dimension, and if you do with DAL for your first few times and the patient survives, it's like, oh wow, okay, maybe I could just restore the posteriors now, and then you suddenly realize you've done a full mouth rehab, right? And so the next thing I was afraid of was, okay, how much can I go here? I think once you overcome the fear of raising the vertical dimension, the next thing is, have I done too much? And so what guidelines do you use, David, to kind of figure out the anatomical limits of raising the vertical dimension? Okay, interjection DAL technique, one of my favorite things. It's like a gateway drug into full mouth rehab. Okay, and I know a lot of our colleagues in America are against it, or they don't believe in it, or they call it unpredictable orthodontics, as I call it as well. But it works, and it can really serve as an interceptive treatment for localized tooth wear. So essentially, localized anterior tooth wear, classically, and you build up the teeth, and now you've raised the vertical dimension. The back teeth are separated. But like magic, okay, after about 3 months, sometimes a year, the teeth reestablish. They, you know, the dentoalveolar compensation takes place, and then the front teeth intrude, or maybe they flare out a little bit. Maybe, I don't know the exact mechanism. Like, we think it's intrusion, but it's pure intrusion always happening. Who knows? But essentially, you've now created space. Before, you did not have space, and then you managed to create space. So it's a wonderful way to treat localized anterior tooth wear. But it's important to also know when you should not do this treatment, and it's better to do a full mouth treatment. So the reason I say DAL treatment is like a gateway drug to full mouth rehab is in DAL, you do the anterior 6 to 8 teeth, and you let the back teeth sort themselves out. Well, sometimes do the front 6 to 8 teeth, but then soon after, just sort the back teeth out as well. It just makes sense. There we are. You've done a full mouth rehab. It's not as tricky as what they say. And the kind of case not to do DAL on is when you've got like dentine exposure posteriorly. Like, if you've got dentine exposure posteriorly, do you really want to leave those teeth to DAL into contact? No, you want to cover those teeth. So a full mouth rehab is more appropriate, because actually you're being additive and you're being more minimal in that scenario. Other times you want to avoid DAL is that, well, if someone has an anterior open bite, then they're usually not going to have anterior wear. Right? Usually it's the people with AOBs that have their mamelon still, or their incisal or halos. So usually they're not going to have wear anteriorly. But let's imagine they did, and you want to now add in restorative material and open the vertical dimension. So they go from having no contact at the front and actually having a space between their teeth to now having extra contact on the front. The reason why that might not be a good idea is because these people, they might not have that much eruptive potential. Think about it. If they had eruptive potential, wouldn't the front teeth have kind of erupted and adapted back into the occlusion? They would have, right? So that's why we say, okay, let's avoid it in anterior open bite patients. Let's avoid it when, you know what, this patient just needs orthodontics. If they've got crowding, why are we darling? Just align the teeth and sort the space requirements out during your pre-restorative orthodontics. And intracapsular issues, if they got major joint issues, they got like history of locking, jarring of their jaw joints, significant pain from their TMJs, that's not the kind of patient we want to be doing any sort of reorganized dentistry. And last few is if you have someone who's got a reduced periodontium, i.e. they don't have periodontal disease anymore, but they used to, but now they have recession and they have some mobility, which you'd expect. But now, do you really want to overload, because dial treatment is like a controlled overloading of the front teeth to allow them to intrude and the back teeth to overrupt. I like that term, right? Controlled overloading. But do you really want to overload, even if it's in a controlled way, teeth that have less bone support to begin with? So really, try and avoid when you got someone with a history of periodontal disease. And lastly, imagine you want to do a dial treatment, but your anterior teeth have all got like root canal treatments and posts inside. Do you really want to do a controlled overloading on structurally compromised teeth? So there we have it, guys, a quick overview of when not to dial. Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I wanted to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
Well, I think again we need to think of it in terms of a rule of thirds, and by that I mean that if we're opening the vertical a millimetre posteriorly, we're probably looking more like 3 millimetres anteriorly because of the nature of the V, if you like, that it's less space. How much am I opening? Prosthetic convenience. So really the space that I need. And therefore, we're never going to be opening more than really maybe 2 to 3 millimetres maximum. It's possible you could open more, but being realistic, we're probably not having to go beyond that. And therefore, that's always okay in my experience so far. So there is a natural limit that occurs because we don't need to open beyond that. And I'm not opening vertical to change someone's face shape. That's more of an orthognathic approach. So for me, it's prosthetic convenience that gives us the space. And again, we're working that out with the technician. And I'm sure we're going to come on to how we do that. But I'm quite comfortable that I can open as much as I need to for prosthetic convenience without causing an issue. And that isn't going to be any more than probably 3 millimetres max.
There's a really good paper by Abduo, which I'll link again. I think we spoke about on the podcast before about vertical dimension. I linked that paper. It's just a fantastic review. I'll post it again in the show notes here. But that paper had a good guideline of, up to 5 millimeters is fairly okay. And so keeping in line with what you said there, measured anteriorly. And then interesting, when you measure that anteriorly, let's say your lateral is worn, down to a 2-3 millimeter stump, right? Upper lateral worn 2-3 millimeter stump. And then you want to lengthen that by 4 or 5 millimeters. You open the bite 4 or 5 millimeters there, and then in different people, this can actually give you a different amount of space posteriorly. You mentioned a rule of thirds, very universal, but sometimes in a class 3 patient, you're getting a lot less. In a class 2 skeletal patient, you're getting a lot more. And sometimes in the past, that's given me some challenges whereby, yes, I've got the right space anteriorly, but I've got these great big spaces posteriorly, and now you're almost like doing a vertical cantilever. You got like an onlay that's like more height than the actual existing tooth there as well. And so I kind of worry about that, David. Should I worry about that? Should I not worry about that? What have been your experiences long term seeing these patients come back?
I think it's to a large extent aesthetically driven, because if we're bonding to enamel posteriorly, given that I'll be using a dual cure cement and not a light cure cement, again, I'm not concerned. I would like to have axial loading wherever possible. But another tip, and again, you're working it out, and you're right, it can be different in class 3 and class 2 patients, but we're working it out in advance. I'm not concerned about the thickness. I'm concerned about the length of the lower incisors. And then a tip is sometimes I will leave the 7s out if they are fully dentate, because that's the area where they may have issues, and those 7s may over-erupt, but it's unlikely. If that's an issue, you could then always add them in at a later date once the patient's adapted, or even put some composite on the occlusal surfaces to just give some light contact. So there are other options, but the extent of the opening, as you say, you're not really going to ever need more than 5 millimeters. I find actually it's very, very rare that you need up to 5 millimeters. So in that sense, I'm not concerned, but you have to have the experience, you have to have the comfort of being able to equilibrate. But because we've gone through the whole process of the diagnostic try-in, I'm comfortable that I'm not opening excessively and that I'm marrying that functional side with the aesthetics anteriorly.
Great. And I think this leads on to the next bit where you've mentioned about doing the visual try-in and then potentially considering testing this, right? Nowadays, we also touched on the fact that composites can be transitional, can be provisional, can be transitional, and we're seeing a boom in injection molding. I think it's a fantastic treatment modality to increase vertical dimension and give a transitional, let them adapt, and then potentially in the future at some stage, the patient knows that, okay, we convert this in ceramics. I'm a big fan of that. But there's just a couple of schools of thoughts here. A really good post by Lucas Lashman will also be coming on the podcast soon. He's a bit of a superstar, and this guy has posted the Marcus Blatz of Occlusion on Instagram kind of thing, some wonderful posts. And one interesting post was, when you are testing, the patient, it takes about 90 days for neural circuits to adapt. And so he was suggesting that perhaps for the experienced clinician like yourself, David, that, because in your hands, what's worked, what hasn't worked, that perhaps, in your case, your judgment and the fact that patients do adapt quite well, you can almost go to definitive without that testing stage. Because when you're testing in composite and then when you're delivering in ceramic, for example, they're two different materials. The brain has to adapt twice, and sometimes it may be better for the brain just to have to adapt once. So I'm interested to know, in your years of experience, how often you might feel that it's safe and best for you still to do the testing and that's working well for you, or do you sometimes go open the vertical dimension, go for the definitives if you like, and let the patient adapt on the definitives? What's your stance and philosophy at the moment?
So historically, when I was less experienced, and to be fair, it was less common that we might open a vertical, we would maybe test drive it with a flat plane appliance, so a Tanner or a Michigan. And I found that there was no one that didn't adapt. And I was doing a lot of flat plane appliances back then, and therefore more experienced than people that might be having a rehabilitation. They may have been having an occlusal splint for TMD reasons. But we have a few other staging points, so we are going to test drive it. Remember that your visual try-in can be spot bonded to the teeth, and the patient can wear that as long as they can clean interdentally. That is a test drive, and so we can test.
And that's a bisacral material like Protrusive Integrity, that kind of stuff. Right?
Where we do the visual try-in, but we actually spot bond it rather than just shrink wrapping it onto the teeth, and the patient can go away with that to test drive it. And we are going to test drive it.
How long for typically? Because people are thinking, how long was it reasonable longevity to expect from something like that?
Well, I'm not a big fan of doing that, but it's an option that we have. And if I do a visual try-on, as I think we touched on last time, I like to be able to take it off to show the patient. But I think you could expect to do that for a week. But also the important thing is that's before we've prepared the teeth. But even if we are preparing the teeth, or when we prepare the teeth, we're still going to test drive it in our trial smile, in our prototypes, in our provisionals. And then you have the option if you are concerned about lab-made provisionals, but those are definitely going to be on for a month and could be on for longer if you want to test drive for longer. And the transitionals, as you say, absolutely I'm happy to do it in composite, but it's going to add more cost to the patient. So if you're idealizing the occlusion and you know through your diagnostic steps that we can give them an ideal occlusion, in that sense I'm then not concerned because I know that I'm down a very predictable path. But for our colleagues who aren't maybe as experienced, we have those stepping stones to use along the way. But I know that if I've got my diagnostics right, I've proved it to myself as much as to the patient, but proved it to myself with my visual diagnostic trying that I know with my bisacryl that I can get to where I want to. It's then a question of being able to execute that, which I'm quite comfortable I can. So I'm not so concerned. And I think you make a good point that it's less adaptation and less cost. But we have those steps or those interim steps should we feel there's a need for them. I'm not advocating always rushing to final restorations, but in my hands, I am actually comfortable proceeding to final restorations most of the time, if not all of the time.
One thing I didn't actually mention, which actually may relate to, when you're testing with the visual try-in and you gain from when you hear them speech and whatnot. But one, we'll talk about do's and don'ts at the end, but one relative contraindication to the limit of increasing vertical dimension is if you open the vertical dimension and then they lose their lip seal, right? When the patient closes together, lips must touch together first, then the teeth, exactly. And so, kind of anatomical, that long face patient, right? If you get a patient who's got a long face, they're not so amenable to opening vertical dimension. And I'm sure we'll talk about that in the do's and don'ts, but I just remembered that. I think it would be a good point now, David, to maybe discuss a typical case. And then because I know you want to bring in the fact that how it's planned with the technician and then at what stage do you scan. If you just talk us through a typical case journey as an example, obviously the example you'll give us can't incorporate every single scenario, but it'll give us a bit of a flavor.
Absolutely. So we're obviously going to do a diagnostic wax up and we're waxing up at the open vertical. So the first question is what extent of the vertical are we opening? And we really want to be taking a CR bite record because once we're in CR, we're on a hinge axis and then we can open the pin quite comfortably knowing that we're in repeatable grounds. So ideally I'd have someone deprogrammed so they're in CR and then...
What's your preferred poison of choice for deprogramming?
I find that a lot of the time I can, with bimandibular manipulation, get a patient into CR because actually what I'm after is their CR contact. And if I can have a record at that CR contact, then that's enough for the lab to be able to mount the models in CR and then open the pin. But that isn't always possible. So then we're looking at a few different options. We've got...
Hey guys, it's Jazz here with an interjection. Right, so these interjections have been designed. We've been going for about maybe 5 or 6 episodes now, as per your request, sometimes I don't want to disturb the guest. I also feel like we just need to explore a topic a little bit more to make it tangible. That's the mission of Protrusive, right? To make things tangible. So he mentioned Lucia jig. Some of you already know what it is. You've made some before, but to a lot of people, they might not know what a Lucia jig is. So let me describe it, right? Classically, it's like something acrylic, right? That you make and you make it to a right shape and you put it on the central incisors, like for example, the upper central incisors, and you create like a flat plane. And then when the patient bites together, now the back teeth are separated and they're sliding around the front on this, what we call a Lucia jig. Okay, so it's made out of acrylic. Classically in the past, something like Duralay could be used, which is like a red acrylic. You can use any type of acrylic, but actually you can actually get these pre-formed ones whereby you inject the bite registration paste into, and then you could pop it on the teeth. It's got like this little plastic unit that sits on the front teeth. And the whole purpose of it is to separate the back teeth and allow the lateral pterygoid muscles to release and relax and allow the patient to find centric relation, i.e. the joints, the condyles will seat. The balls will go into the cups. That's my analogy of the condyles seating into the fossa. And when you get the patient to go, grind left and right and grind forward and back, they'll keep returning back to the same place. It's kind of like a Gothic arch tracing, if anyone knows that from complete dentures. But essentially, we're able to find this repeatable position that's comfortable. And then we know that the muscles are relaxed and this is essentially their centric relation. Now, for those of you who are watching this, then you've seen me kind of play in the background a clip showing a Lucia jig in action. It's not so important because a lot of people listen to this while they're running, chopping onions, whatever they're doing. So I hope that made sense. But if you want videos of different ways of deprogramming, then one of the lessons we have in OBAB, our Occlusion online course is a deprogramming masterclass. So I show you all these different ways of deprogramming the patient, including the leaf gauge to a lucid jig, using a chin point lift technique, which I think the best is a hands-off approach, right? So lucid jig is great, leaf gauge is good, and there's different times you might consider each one. Essentially, the goal is to seat the joints and find that repeatable, reproducible, and comfortable position, aka stable condylar position, aka centric relation. There we are. Let's return back to the episode.
Leaf gauges, we've got a Lucia jig, or we have the Coist deprogrammer, which is effectively an upper removable appliance with a flat blight plane just on the palatal of the upper anteriors, which is similar to a Lucia jig in that it's going to deprogram the muscles. So of those, probably I most prefer a Lucia jig, but alternative in my next would be a leaf gauge. So the two different ways is that if they're deprogrammed, then you can use the fact they're in CR to then open them up to the extent that you want. And certainly that's when a leaf gauge becomes useful, because you know you've got them at that first point of contact and can put bite registration pace at potentially the desired opening. But the flip side of that is we don't always know how much we're going to open. So the most important is that you have a bite record at CR, and then the technician is going to work out what space they need. And anything I provide them with is an estimation until they start waxing up the case, whether that's a typical analog wax up or absolutely a digital wax up. And so two different ways, but for the less experienced, the safest is to give the lab a bite record at your proposed increased vertical.
I'm just writing that down now. That is that exactly it.
But that isn't always possible. But as long as they're in CR, the lab can adjust that, because they're going to work out what is needed. And then they're going to make a bite jig at that and that increased vertical. Effectively, I like to think of it as almost like a Lucia jig at the front. And we're going to come
on the articulator.
On the articulator.
Yep.
Before they wax up or after they've waxed up, I need that jig, because when it comes to the technique that we're using, that's my most important part, apart from the putties that I have to make the bisacryl. So it's a question of how we decide on the extent of the opening. We're in CR, so they're in hinge access, and then our anterior jig. And we'll come on to that in the techniques of how we then use that. But that's going to give our extent of opening, and then the lab are going to wax up. We're going to do our visual try-in, and we're going to check that we've still got an oral seal. And that goes back to what we were saying about making sure we don't have overly long lower anterior teeth. And so we've worked it all out, and then we could sort of come on to how we do it, unless you have any other questions about the
No, I'm happy for you to talk, because that's a good point about the jig, and then importantly how you then use that in the clinic once the technician's made it.
So assuming we're doing an upper and lower full mouth, I'll have the anterior jig in, and that's going to tell me my occlusal clearance, because that's what we're trying to work out. The preparation facially, whether it's full coverage, something we touched on in the previous episode, but I want to know the amount of opening. Now, when it comes to doing an increased vertical, some colleagues prefer to do one arch one day, the other arch the next day, and that's fine. I'm quite comfortable going through a very long appointment, that's a full day appointment, and the advantage for me is that I can work out which is upper and which is lower. And
what do you mean by that, sorry?
So how much I'm adding to the upper, how much I'm adding to the lower, where the distribution between the extra occlusal coverage between upper and lower. And doing that as a same day case, I find that easier to work out. But basically the anterior jig goes in, and I'll do a posterior sextant on one side. Let's say it's the right hand side. I'll then work out the distribution of that increased vertical, or how much we're adding occlusally to the upper, how much we're adding to the lower, and I'll prep upper and lower sextants, and I'll make temporaries for those upper and lower sextants with the jig in, knowing that I'm in the correct vertical. I'll then prepare
this jig. Sorry, one thing, David, like this jig way of doing it. So I imagine this is not flat plane. This is indexed, because it guides them into the exact position you want, right?
It is indexed, but I want to be sure that that is at CR. And ultimately what you can do is, once you've got it indexed, once you've removed the posteriors, you can remove those indentations, and you effectively convert it from a jig that's actually physically indenting into the teeth to a Lucia jig.
And then you're observing that they're literally biting together, and that gives you so much confidence.
Exactly. So it's effectively acting as a deprogrammer as well as a jig down the line. But I'm not using it until I've made posterior sextants right-hand side and then left-hand side, because then I actually want to equilibrate those posteriors. And if you then flatten that anterior jig out to remove the indentations, it's acting as a deprogrammer so that your posteriors are in the ideal position vertically, but also equilibrated so that we know the patient's in CR. We can then take out
interested to know the following, actually. I'm sorry for interrupting, but I think there's so many questions which I think will be helpful to everyone. Is what percentage of the time, right, do you put the posteriors in, right? So you got the left and right posteriors with the bisical from your temporaries, provisionals basically with the bisical, because we're in our pretend full mouth scenario. You've got the anterior jig, you've now flattened it out, and then you find that, whoa, the lab have nailed it, your CR record was amazing, the patient's occlusion is spot on, versus I need to do some adjustment, okay? So is it that 99% of the time there is a bit of adjustment needed, or more that actually there's not adjustment needed? I'm just trying to give those young dentists to know what to expect when they come onto this kind of dentistry.
You'd be surprised how much the lab often do nail it, but I would expect some minor adjustment, but not significant.
Yeah, if it's significant adjustment, that means there's a huge issue with your bite record.
Yes, absolutely. But again, having gone through the diagnostic process, I'm already a step ahead of that because I know that isn't the case because I've already done a visual try-in to confirm where I'm up to. So
yeah, and then like you said, you did the visual try-in, you took a putty, and then that guides the lab for this provisional stage. Very important.
So yes, if I've made more adjustments, I'm making new putties, but I've gone through that process. So am I expecting some adjustments? Sometimes that isn't necessary, but often some very minor adjustments, very, very rarely, if not at all, if never, to have significant adjustments.
I think this reminds me of something that Ian Buckle taught me, which is like centric relation is like playing golf, right? You're not going to get a hole in one, right? So sometimes you get like a little bit closer, like with your bisical visual try, there's a bit of adjustment to do then, right? And then you take a putty. And then on the day of provisionalization, you're a little bit closer still. And then at the delivery, you're a little bit closer still potentially, you know? So, or there, you definitely want the ball inside then.
And that's a very good point, because even when I fit, I'm not expecting to have to do no adjustments. There are always going to be some adjustments, but they get less and less. And I mean, we'll touch on how we record that for the lab. But yes, not expecting a lot of adjustments. So we've equilibrated our posterior sextants, left and right. Then we can take out our anterior jig. And we then have our clearance anteriorly. So we then know how much we're preparing. We've already done the diagnostic of whether the uppers are full coverage. And certainly in an unrestored case, I'd be ideally not wanting to go full coverage. So my amount of vertical opening would be to give me the length of the lower incisors that I want to, because I don't want to have to prep the palatal of those uppers, because then technically they're crowns. And I'm talking about a new case. A full mouth rehab will be a very different situation. So effectively, we've prepared and we have 6 lots of temporaries, 3 upper sextants, 3 lower sextants, which are all removable in their own right.
At this stage, you tend to favor using acrylic, like shells, or you like bisacryl? What do you prefer?
I'm still very comfortable with bisacryl. If it's palatal uppers, then we're less concerned about the upper anterior temporaries, because it's our lower anterior temporaries that give us the extent of the vertical against the upper palatals. If the uppers are full coverage, then bisacryl is going to work fine. So in that sense, with the uppers as veneers, it's maybe harder to have a temporary you can take on and off, but it's less of an issue, ironically, in that situation. And when they're full coverage, I will have 6 anterior crowns that I can take on and off, because the next crucial aspect is how do we record that vertical for the lab? Bearing in mind, I've equilibrated my posteriors. That's allowed me to equilibrate my anteriors. So my bisacryls are all equilibrated at my new vertical. I will then take out my posteriors for my bite registration, and I'll have my anteriors upper and lower, or certainly lower if it's just an upper veneer case, in place. And then I can just put bite registration paste in my posterior. And I'll do that both sides, and I'll do it 3 times because I want 3 bites. So we'll do that and keep those separate, and then I'll take out the anteriors and I'll fill that in. So I have a full occlusal registration equilibrated in CR at our new vertical dimension. And I'll do it 3 times, and when it goes to the lab, we hope, and most of the time, all 3 are the same. If not, you'd hope that 2 are the same. If all 3 are different, then maybe something's not according to that. But you'd be amazed that all 3 are often exactly the same, but certainly 2 of them. So we have our prep to prep bite registration at an increased vertical.
And what I love about this is that, sometimes I'm concerned about using, stone bite, futon ID, whatever you're using. At this stage, you have plenty of thickness and rigidity of that because of the space we have. And that gives you so much more confidence.
Absolutely. And bite registration material, there are many around. Futon D is a great material. For me, it's a little bit hard. I prefer Blue Moose, but I get extra fast because otherwise it's a long time to set. But speak to your lab technician. Often they will be trimming that down because they only want the very cusp tips in there. So the rigidity's less of an issue because you're going to have quite a thick, sturdy bite registration. But I mean, it goes back to not on topic, but when we do a single restoration, you won't really want to do a bite registration over the other teeth, because that's when it gets in the way. But we're talking a different scenario where we have a much thicker bite registration. And so therefore the material for me is less of an issue. But I'm comfortable with Futar D, Blue Moose, DMG do a great product, O-Bite. Not to be confused with Luxabite, which is too hard for a bite registration paste, but is great as a splint or a sort of a liquid Duralay that we can inject and splint together implant impression coping, certainly in full arch cases. So we've got our bite registration material as a full arch, and that would be our prep to prep. I will also do a prep to temp bite registration and a temp to temp bite registration, which is allowing our lab to cross mount our preparation models and our provisional models so that they can work out the space distribution and work out everything is the same when it comes to making the permanent restorations.
And at this stage, you're taking a new FACEBO record for your technician?
Absolutely. Onto the prepared teeth. So that's my workflow to do the preparation and to get the bite registrations. And we'll have 3 lab bags. And inside one of those lab bags, there'll be another 3 bite registrations. So there'll be 3 prep to prep. There'll be just 1 prep to temp. And there'll be just 1 temp to temp bite registration.
Your assistant has to be so switched on to make sure the labels are there, and then everything has to be in nice sealed boxes, not in like flimsy Ziploc bags. You need everything protected. You don't want things to be shattering by the time they're getting to the lab. Do you ever use custom incisal guidance tables?
The answer is I have done, and I'm quite comfortable with using them if you're reproducing the guidance that you have. And the lab may choose to make one from your temporaries to help them reproduce it. And again, it's a way that we can record the steepness of our incisal anterior plane for the technician, or for the technician to be able to reproduce that, whether that's from something you're wanting to copy in the patient's natural dentition or wanting them to copy from your provisionals. So it has a place, but if the technician's done the digital wax up and it's all in-house, that they're probably going to be able to copy what you have, but it's always an option as an extra tool to confirm that they're copying what you have. But I think we must always remember that we have to be able to be adjusting in the mouth, because the best articulator is the mouth. And so we don't want to give patients overly steep incisal guidance, but it needs to be steep enough to give us posterior disclusion. And a custom table can be useful to help confirm that, if nothing else.
Wonderful. Those are my main questions. I want to just talk about any do's and don'ts that you want to just come to mind on the clinicians who are starting their journey, to just remember to save them for getting into trouble.
I think it's a fairly classic one. Don't try to run before you can walk, and absolutely don't be doing work that's beyond your scope of knowledge. And so initially, get a good foundation in occlusal training. And if you're used to doing equilibrations, if you're used to adjusting flat plane appliances, I think that's a very good start, because it's going to give you the confidence to be able to move forward. Be comfortable and confident in your restorative and your preparation skills. Going back to Schillingberg, knowing how to prep is definitely very important. And don't do anything beyond your skill set. But going through the pathway, especially if you've had your occlusal training, you're comfortable doing equilibrations, you're comfortable adjusting your flat plane appliances, we're not doing anything massively different from that. And with the whole planning stages that we have gone through, we're not taking steps into the dark, because it's a very predictable process. We've gone through that. We know the aesthetics. We know that we can achieve the function. It's then just a question of taking your time. And for me, this is a full day appointment. Patients are instructed, wear comfy clothes, have a good breakfast, bring some music in to listen to. It's going to be a long day, but you can have a break, and be aware that you can split it into 2 days if you'd rather, and fully inform your patients about what's involved would be my list.
Mm-hmm. Yeah, the last thing you want is a patient like, what the hell just happened? Yes. You can imagine that. Yeah. Oh. David, thanks so much for sorry, go for it.
We're just with the diagnostic process, the patient is aware of what's happening. They're fully invested. They understand their level of dental knowledge has gone up, because they have to be aware of what they're going into. And it is a long day, and patients invariably get very, very tired at the end of the day. But the results, that memory fades very quickly when you give them the mirror and you give them the functional aesthetic result that they've wanted.
You forget about the flight and the ear pain that you had when you have your pina colada at the beach.
and our wives and our female colleagues, if they have gone through labour, they will probably tell us that the end result is worth it. But
Well, that's a great point to end on. David, thank you so much for this early morning session. We covered a lot of ground there, and I think kudos for really covering a complex topic. Like, wow, like this is such a big topic, and I'm really happy with the rabbit holes we went down. David, please tell us more. What are the channels that I can get Protrusive to learn more from you, my friend?
So as we touched on last time, there is going to be a website, ppcontinuum.com. Sorry, I can't let you have that one, Jazz, as you asked last time. But there will be some resources on there from myself, but from other colleagues. And Kushal Gardia at ACE, I do run the additive program for veneers and minimal invasive dentistry. And you've inspired me, Jazz, that I'm going to put together a program for doing the open vertical as a course as well. But I haven't got that completed yet.
Let me know when you do. I'll put it in the show notes, my friend. Someone as experienced as you, it's a great skill to learn, and to have that would be wonderful.
Thank you. And I'll be doing that, I think, as a hands-on with Kushal Gardia at ACE. And obviously, you can Google me. I'm happy to help in any way I can. And another point that it's not just with me, to find a mentor, because one thing we didn't touch on is that you can do this sort of a case with someone as a tag team. So you're both clinicians together and working it out with your mentor, where you treat the patient together. And your mentor might treat one side, you might treat the other side. And that would give you the extra confidence to...
That is rocket fuel. That is rocket fuel for your career. Honestly, great point.
And I know you're working on the mentoring program, and I think doing the case together will give you the confidence that it's the first few that obviously understandably anyone's going to be concerned about, and to give you the confidence to get through that, that's also an option.
Amazing, David. I'll put the links there for you guys to learn from David. Thank you for your time again, my friend.
Thank you very much, Jazz, and well done to you.
Thank you. Well, there we have it, guys. Thank you so much, as always, for listening all the way to the end. What I did do in this episode is I put in a few interjections. I don't always do this, but when you have a very confusing topic like vertical dimensions, multifaceted, I hope those interjections were useful. And if they weren't, please could you comment? Please could you let me know whether you're watching this on Protrusive Guidance or on YouTube, or maybe you're going to go on Instagram at Protrusive Dental, you're going to DM me. Let me know, were those additional interjections, were they helping you or were they hindering you? We love your feedback on Protrusive. This episode is eligible for CE or CPD, depending where you are in the world. We are a PACE approved education provider, and on our platform, Protrusive Guidance, you have access to over 350 hours, including our masterclasses and on-demand webinars. And our mission really is to make dentistry tangible. So check out www.protrusive.app and maybe start a free trial today. As always, any links that we promised, I'll put them in the show notes, so scroll down. If you want the premium notes, which is like a PDF summary of everything we discussed, it's like revision notes, it's like really good revision notes for every episode. Again, they are accessible under the episode if you're watching on Protrusive Guidance or in our Protrusive Vault. At the time of recording today, we have over 3,000 strong community of the nicest and geekiest dentists in the world. And so Protruserati, thank you so much. I appreciate your support and for returning. And if you're new to the podcast, please do hit that subscribe button. It really means a lot to us. I want to take a moment to thank my team. Our CE queen is Marie, who's the one who issues your certificates. And this episode was edited by Gian with collaboration from Chriselle and Nav. Thank you to my lovely team for doing all that work so I can be a father, be a dentist, and be able to watch IPL cricket on Sky Sports. As always, I'll catch you same time, same place next week. Bye for now.